we are very happy to invite our distinguished guest speaker from the Chinese University of Hong Kong, Professor Jim Hu, Hu Lingfang. I would like to briefly introduce the Professor Hu. Professor Hu is the emeritus professor of medicine from the Henry Liang Research Professor of the Gerontology and the Geriatrics. Although she's retired for 9 years, but she's still very active and very productive. She now is currently the director of the Institute of Aging and also the co-director of the Institute of Health Equality. She used to be a chairman of the Department of Community and Family Medicine in CUHK, and also the director of School of Public Health, and also the chairman of the Department of Health and Therapy. So today she will continues the topic about the intrinsic capacity and give us a talk with the topic with the exploring the VO2 max as the objective measure of the vitality domain of the intrinsic capacity. Let's give a big hand to welcome Professor Wu.
Thank you for your kind introduction, and thank you for inviting me to share my thoughts on this topic. Following on Professor Landy's background, you would have seen that if you're a clinical researcher or people in public health deciding on how to provide health service, preventive health service, the scene has changed from one focusing on individual diseases. There's still a lot of people just focusing on individual diseases. And then for the past 10 to 20 years, we've shifted from the geriatric perspective to focus on frailty and sarcopenia as well as outcomes and planning our services accordingly. But as you've heard, in 2015, the World Health Organization started this concept of healthy aging, focusing on function. And then they introduced the concept of intrinsic capacity and the life course approach to promoting and maintaining intrinsic capacity. So, but intrinsic capacity is not widely accepted yet because it's a concept. I mean, as you've seen from the slides, nothing much happens when you reach peak until about 50, 60. Then you start to decline. So you can ask, well, what's the difference to the current approach to preventing pre-frailty, cognitive frailty, and all that? Because we are not into the maternal child health and school. Somebody else is doing that. So it's still a controversial topic. I think the strongest proponent is the WHO, and there's a lot of talk about it because currently we're in the UN Decade of Healthy Aging. And the United Nations has asked the WHO to provide an update. How are you getting on with all your measurements, proposed measurements? So, so I'm going to explore this idea, and as you heard, there are 5 domains: cognitive, psychological, sensory, vitality, and locomotor. So I'm going to talk about vitality. What is vitality? Now, you also heard about ICOPE. So these are conceptual domains of intrinsic capacity. But what do we do about it in public health, or if you're thinking of your own health, what do you do? So the ICOPE has created this thing where it's a integrated medical social screening in the community, and anybody can do it. You don't have to have nurse or doctor or anything. And see, you can see that there are now 6, because sensory is visual and hearing. Limited mobility, depression, cognitive decline. Initially, they decided on malnutrition and an indicator of vitality. Because underlying vitality is whether your body's metabolism is working normally or whether you're having age-related deficits, right? So So essentially, it's an expression of cellular senescence. So this is a geroscience bit. What's the underlying process that gives rise to these terms? So cellular senescence, and then you have adverse metabolic outcomes, and then corresponding clinical phenotypes. Of course, with mitochondria is the powerhouse, and if you have mitochondrial dysfunction, you have adverse outcomes. So might contribute to reduction in cardiorespiratory fitness, for example, maybe metabolic syndrome and central obesity, loss of muscle mass and quality. And in the last analysis, what's the difference to the underlying pathophysiology of frailty and physical resilience? Are we all talking about the same phenomenon, but using different terms? So conceptually, it's, there's no universal agreement. Similarly, there's no agreement about how it's measured. Now, you have to measure it if we're going to take this concept into practice. This thing, fatigue, is the latest that the measurement group has decided on. So this is a questionnaire. So after a lot of discussion, they thought that vitality is a manifestation of low vitality is fatigue. So you immediately would think, well, this is similar to Fried's concept, right? Because the phenotype, one of them is fatigue. And so how do you measure fatigue? And then somebody did a literature search and so on and found there's a fatigue scale of about 20 items with reasonable psychometrics. So that's the latest thing from WHO, published in the October supplement of Age and Aging. Now, the French group, Bruno Vallis' group, recently looked at grip strength, MNA for nutrition, and plasma biomarkers, mainly the inflammatory markers, and also markers of mitochondrial function. And they found that they're all predictive, but the plasma biomarkers seem to be best. So because of the similarity, this concept of fatigue, can we use vitality measures to be used as early indicator of frailty? That's an interesting thought. Now, you can measure energy expenditure and metabolism using VO2 max. It's an objective measure of cardiorespiratory fitness. People in sports medicine have been using it for a long time now. So basically, it measures maximal oxygen uptake using calorimetry. And it consists of resting metabolic rate plus energy expenditure during exertion. And body composition independently contributes to resting energy expenditure. In the past, we have examined body composition and maximal oxygen uptake in healthy men and women in the community. And we found that age, fat mass, and lean mass are independent determinants of maximal oxygen uptake. And furthermore, the cardiorespiratory fitness is not the same as physical activity. They are distinct from physical activity and metabolic syndromes, but they're all related, but separate. What happens as you get older, with age, VO2 max declines. And what determines this decline in VO2 max is body composition and levels of physical activity. This is digressing into this concept of sarcopenic obesity, where in this condition, there's loss of muscle mass and there's increase in metabolic load, increased cardiovascular risk factors. So we just use a simplistic way of using a ratio of appendicular skeletal mass divided by total body fat. Just a kind of useful way of expressing this. And there are cutoffs for different outcomes using CART analysis. So we've built up this kind of picture with what happens to you as you get older. And finally, I just want to say that the difference between physical activity and VO2 max, the relation with all-cause mortality, they're different. So you can have different combinations. The best is that you're active and you're fit. So this is the reference. And the worst if you're inactive and you're unfit. So the hazard ratio is 4.5 times. But in between, you have inactive fit and active unfit. And it's in between this combination. So we're all measuring slightly different things, so in addition to just physical activity. So then one can ask this question, can we use VO2 max as an objective indicator of vitality? Is it linked to other intrinsic capacity domains, such as cognitive, locomotor, or psychological domains? And then finally, can we think of this as a biomarker of early frailty by its ability to predict frailty, sarcopenia, and sarcopenic obesity using that simple ratio that I mentioned. So this is what we set out to address, these research questions, using this OS cohort, 2,000 men, 2,000 women, where it was collected around 2000, year 2000, and at 7 years we measured the VO2 max. And then we followed them up for another 7 years and look at 14-year outcome. So, you know, lots of people drop off. Some people cannot ride bicycles and so on. But anyway, we ended up with some 1,176 subjects. We looked at all-cause mortality data at 14 years. So that's 7 years after we measured the VO2 max in men and women separately. So we put people on the bicycle ergometer. So some people cannot ride bicycles, so they're excluded. And then we get them to pedal as hard as they can with a face mask to measure oxygen consumption linked to a metabolic analyzer. People who have a history of chest pain on exertion with a diagnosis of ischemic heart disease or ECG abnormalities, uncontrolled blood pressure are excluded. And we set a minimum pedaling rate of 50 RPM, and termination is when cannot, when there's no further increase in VO2 max with increasing load, or participant cannot continue, or they attain 85% of age-predicted maximal heart rate. And the 14-year outcome variables is MOCA, chair stand, gait speed, grip strength, total body fat to appendicular lean mass ratio using DEXA, GDS 15, the frail scale, and SARC-F. So we try to relate 7-year VO2 max measurement to 14-year outcome. And so this is just a brief showing that the top part are the continuous variables. We looked at the outcomes using a continuous way in the regression. And these two are categoric variables. The frailty, Morley's frailty classification, 0 and 1, and sarcopenia with greater than 4, yes or no. So you can see that there is significant prediction for all of these, but the directions are different. Some are reverse. And the next slide just shows visually what direction it is. So, for example, it's positively correlated with cognitive function, but negatively with chair stand time, and depression, and frailty. And this is a categorical variable, so higher VO2 max has a protective effect. So this is just from the sake of visual presentation. Now, in sports medicine and some respiratory medicine, where they're interested in VO2 max, it is recognized that many people cannot do this bicycle ergometer test. So they use 6-minute walk distance. So I think Professor Landy mentioned that it's been used. So how far can you walk in 6 minutes? Well, pulse pressure, I won't talk about pulse pressure now. So if you look at the ROC curve, this is all-cause mortality for men. The blue line is peak oxygen uptake. The red line is 6-minute walk distance. And incidentally, we also looked at the 6-meter walking speed. The ROC curve is not bad. I think ignore pulse pressure for the time being. It just confuses things. The AUC is not bad, 0.74, something like that. So you get a similar result with all-cause mortality in women. And if you look at cardiovascular mortality for men, you're getting quite good predictions as well. For women, the results are not so good. That the 6-minute walk distance, the 6-meter walk speed is not so good in predicting. So I think these findings support the idea that you could use VO2 max, but then because it's very difficult to do, because we excluded a lot of people, we could use 6-meter walk distance instead, right? So this is to show what's the relationship with the other IC domains. So geriatric depression scale, gait speed, MMSE. So if you look at VO2 max, it has a direct effect. Asterisk means that it's significant. It has a direct effect on the outcome here we consider is change in IADL. Direct effect. Does it also exert indirect effect through these other parameters? Well, VO2 max affect MMSE, it affects gait speed, and reverse association with depression. But it's only the indirect effect through gait speed that affect the change in IADL. So let's say we don't want to talk about VO2 max because it's too difficult to do in real life. Let's just do the 6-meter walk distance. And essentially you find exactly the same thing, that if you, direct effect is a direct effect here. 6-meter walk distance significantly affect cognitive function, gait speed, and depression. But it's only through the gait speed indirectly that there's an indirect effect that affects ADL. So this is just a table to summarize the direct and indirect effect of this mediation model. And see, there's a direct effect, significant direct effect, also a significant indirect effect. But the indirect effect is only mediated via the gait speed. So what I'm saying is all the findings very similar to Professor Landy's presentation in another sense. And if you look at the fitness measures of the mediation model, it's good. So I just want to conclude that in this current debate about how to measure vitality, if you use the VO2 max and then subsequently, instead of using the bicycle ergometer, you can use 6-meter walk distance, then maybe we can use 6-meter walk distance in our screening rather than other scales. Maybe we don't need to use biomarkers. We don't need to take blood to look at inflammatory markers. I think we need to compare that, because when you're working in the community, it's always good to have a quick test, quick screen, and then you can, depending on the result, you can design your intervention, mainly in terms of lifestyle modification. And finally, because we looked at frailty and sarcopenia as a 7-year outcome, it's predictive. So we can say that we can also consider this measure as an early indicator of frailty. So from a public health point of view, and from a clinician looking after people in primary care, this kind of information is going to be very useful because we've been being criticized that we're too negative, focusing on deficits. So I think there's room in primary care to detect these abnormalities and then create enjoyable programs. But from the policy point of view, I have my doubts about intrinsic capacity because governments who look at health, they look at deficits, they look at indicators of deficit. Perhaps they're not interested in indicators of how good you are, right? So I think that there might be problems with pushing policy in that direction. Nevertheless, I think conceptually understanding the science underlying all these age-related changes is good. It's very interesting and it would guide our practice. So I'll end here. Thank you for your attention.
Thank you very much for professors who was talking about the vitality domains of the intrinsic capacity.